Welcome back, and let's talk today about the middle mediastinum. In the last lecture we talked about the superior mediastinum, and we did elaborate on that. We did finish all the great blood vessels of the superior mediastinum, the veins, the arch of the aorta and its branches. So just to put things where they belong, the first lectures were about the veins and the arteries within the superior mediastinum. Today we will explore the pericardium. We will open it as it is the middle mediastinum. We will talk about the ascending aorta, the pulmonary trunk, and of course we will talk about the pericardium itself, and in the next lecture we would talk about the posterior mediastinum, and by doing this we would conclude talking about the mediastina and their contents. Next we would talk about the anatomy of the heart, then the embryology of the heart, and in between of course we would touch on all the important histological features of the heart itself and the blood vessels. Now, just to begin with, the middle mediastinum contains the pericardial sac, which include not only the heart, obviously, but also the within the pericardium, the ascending aorta, pulmonary trunk, lower half of the superior vena cava, we did mention that, small part of the inferior vena cava, very small part of the pulmonary veins. Also we do have here some sinuses, reflection of the pericardium, but we will focus on the pericardium and on the ascending and the pulmonary trunk. So those are our objective to this lecture. In this diagram, as you can see, the pericardium has been opened. These are the edges of the pericardium, and also the heart itself has been removed, and you can see in this very beautiful diagram the structures within the middle mediastinum. Those are the bifurcation of the pulmonary trunk. Here the pulmonary trunk itself has been removed. The lower half of the superior mediastinum, also here the ascending aorta has been removed, although this part is considered part of it. Obviously small parts of the pulmonary veins and small part of the inferior vena cava. Now before we continue talking about different parts of the aorta and the pulmonary trunk, let's just talk about the pericardium. Now this diagram summarizes the embryogenesis of the pericardium. As you should imagine, I'm sure we talked about this in the first year. However, it's always good to remind you about the embryogenesis of the pericardium. Now, you need to imagine that the heart itself is invaginating the pericardial sac, never getting inside this area. So as if you putting your finger inside a balloon without your finger touching or reaching the air within this balloon. So the heart here represents, the finger represents your heart, and the pericardium represent the balloon itself. Now, as you can see, the heart would invaginate this balloon, and as it does so, it takes with it this layer, and we would call this layer a visceral layer. We will call it the visceral layer of the pericardium. The same story has been repeated with the peritoneum. The same story should be repeated for you with the pleura of the lung. So this is the visceral part, and what has been left here, we would call it the parietal pericardium. So this is all parietal. Now, as the heart gets more and more inside this balloon, the space here between the visceral and the parietal and the visceral, which would be the pericardial cavity, is decreasing. So as you can see, the space is decreasing until the two layers, the visceral one, this one here, sorry, the visceral one here, and the parietal one, I'm just trying to use the same colors so you wouldn't get confused, the visceral and the parietal, until they reach a potential space. If you to dissect the pericardium, you would see that the pericardium from inside is adherent to the heart in terms of being a potential space. There is a space between them, but this space, a potential space, it's never like a true space, huge space. It's never like this. It's a potential space, and if there is an inflammation, this space would be filled with exudate or with pus, and then a cardiac tamponade would develop. We will talk about this as we proceed. So eventually what we have here, we have visceral pericardium adherent to the heart, and another layer here, which is the parietal one, all over this area here, and between them we have a potential pericardial cavity full of fluid secreted by the serous membranes. These two membranes are considered to be serous, and they secrete, of course, lubricating fluid to minimize friction between the visceral and the parietal layers. Now, in all organs in your body, this is the story. Two layers, visceral and parietal. This is true for the intestine. This is true for the lungs, and maybe it is true even for the brain, if you consider the dura mater, pia mater as layers of fibrous tissue to protect the brain itself, which is true in a way. However, the heart itself, because it's beating all the time, it has to be the friction with nearby structures has to be minimized to its lowest possible range, and that's why another sac would surround the parietal layer. This sac is the, or let's put another color here, this sac is the fibrous sac. So imagine that the heart is within two balloons. One of these balloons has been invaginated by the heart. The balloon give this heart two layers, the visceral and the parietal, with a potential space called pericardial cavity. Then another layer called fibrous pericardium covering all these structures. This is a tough fibrous tissue. Now, if you, as a surgeon, to dissect the pericardium, here you open it, and I will show you this during our practical next week practical session. The outer side of the pericardium is rough. However, the inner side, which is the parietal layer of the serous sac, is smooth. Therefore, when you open the fibrous, it goes without saying that to it is adherent the parietal of the serous sac. So you are inside the pericardial cavity immediately. More on that during our practical session. We would highlight all these facts. This diagram is also a good one to explain the visceral, and this is the parietal surrounded by tough and of course very strong fibrous sac. The parietal gets attached to the fibrous, and therefore if you to cut through the fibrous part, which you face when you dissect when you open up the thoracic cavity, you would see the fibrous. If you to open it, it goes without saying that you would open certainly the one that lines it from inside, which is the parietal layer, and you would be inside the pericardial cavity. Now the visceral layer, we would eventually call it the epicardium, as it is a very thin layer covering the outer surfaces of the heart, and we consider it as part of the heart. So it is acceptable if you say visceral layer of pericardium, or if you say the epicardium, bearing in your mind that this is nothing but a layer from the pericardium. Also in this diagram we talked about it, the visceral and the narrow space between them, the pericardial cavity. Now let's talk about the outer layer, which is the fibrous one. Is a cone-shaped bag with its base on the diaphragm and its apex continuous with the adventitia of great blood vessels. So it is a cone shape, its base attached to the diaphragm and its apex continuous with great blood vessels, and also we will reflect this during our practical session. The base is attached to the central tendon of the diaphragm and to a small muscular area of the diaphragm on the left side. Anteriorly, it is attached to the posterior surface of the sternum by sternopericardial ligaments. Now, if I to reflect on what's going on here, it's just as if we give the heart a very smooth protection from the balloon, the serous balloon, visceral and parietal, and the heart moves protected by the pericardial cavity within these two layers in one balloon. Now the whole balloon and the heart has been protected by the fibrous. It is tough, and we can connect this fibrous to nearby structure. So the fibrous is the one that gets fixed to nearby structure, and inside it is the heart moving freely. This is my reflection on this genius design of the pericardium, giving the pericardium the ability to move without friction, and also to be fixed in this area, not only by the great blood vessels as we would say about it in just moments, but also by fibrous structure that attaches to the, for example, to the sternum and to the nearby structures. Now the serous pericardium has two things to deal with. The parietal layer of serous pericardium is continuous with the visceral layer of serous pericardium around the roots of the great blood vessels. Don't you ever forget that this is the area where we invaginated the balloon. Here the roots of the heart would be, and there were the two sacs, the serous and the parietal, which were a continuous balloon, but we did invaginate them. So wherever you invaginate, this area would be where the parietal and the serous, the visceral, be continuous with each other. This is true for the lung as well. Now the serous pericardium, this does make some reflection. This reflection of serous pericardium occur in two locations: transverse pericardial sinus surrounding the arteries, the aorta and pulmonary trunk. This sinus lies posteriorly to the ascending aorta and pulmonary trunk, anteriorly to the superior vena cava and superiorly to the left atrium. Now I will just also mention the oblique pericardial sinus, and I will jump into their explanation, how they become how they unfold themselves. As you can see, the heart in embryogenesis, it wouldn't be a pyramid shape that you are familiar with. I will tell you later on that the heart was like a tube with two ends, arterial end superiorly, and it is fixed to the aorta, and it would be continuous with the aorta, and inferior end attached to the venous end attached to the lower parts. We would talk about this later on. Now, as the heart gets larger and larger in size, the lower part would be free to move and fold. As you can see, part of this balloon which surrounds the heart, which is the serous sac, gets trapped in between the arterial end and the venous end. You don't need to go into these details how this reflection would take place, as I will sure talk about it in a series of lectures about the development of the heart. But as simple as you can imagine it for now, this is a tube, has two ends. Now the tube is unfolding, is folding up on itself, trapping between the arterial end and the venous end, as you can see, a transverse sinus. So this transverse sinus has some clinical importance. We would talk about it. As well as the transverse sinus, there is another sinus, which is the oblique sinus, also as a result of this reflection. So the heart folds, and as it does so, some of the serous sac would get trapped, forming the transverse and the oblique sinuses. Now, when the pericardium is opened anteriorly during surgery, a finger placed in the transverse sinus, as you can see. Now, this is the best way to explain this. What is in front of your finger? Nothing but the arterial end. What is the arterial end? It is the future ascending aorta and the pulmonary trunk. And what is behind your finger? It is the venous end. Go back to this. Venous end, arterial end, between them transverse sinus. Now I am putting my finger here, and in front it two arteries, pulmonary and the aorta. Behind it, of course, the superior vena cava. The transverse pericardial sinus is especially important to cardiac surgeons. After pericardial sac is opened, anteriorly a finger can be passed through the transverse pericardial sinus posterior to ascending aorta and the pulmonary trunk, bypassing a surgical clamp or to ligate tubes, and of course to carry on the circulation in this way. So surgeons, they use it. Now as you can see in this diagram, the arterial supply to the pericardium. Now so the main artery is the internal thoracic artery. Smaller contribution of blood comes from musculophrenic, of course, which is the terminal branch of the internal thoracic artery, bronchial, esophageal, superior phrenic arteries, and of course for the visceral part of the pericardium, the coronary arteries, and also we will talk about the epicardium. We would talk about its blood supply. So as simple as it can be, the main blood supply for the pericardium, it is this long artery, which is the internal thoracic artery, as it passes on the pericardium, and of course it takes from other nearby sources such as bronchial, esophageal, superior phrenic arteries, and the visceral takes from the coronary arteries. The venous drainage of the pericardium is from the pericardiophenic veins, and they go to the brachiocephalic or internal thoracic veins, variable tributaries of the azygous system. Now the nerve supply of the pericardium has to be put in its way to understand it. Whenever we talk about an internal organ, you have to consider facts about internal organs. Do you need these organs to feel somatic pain? Do you need these organs to be totally autonomic, muted organs? You don't need to know anything about them. And in each system you would see different representation of these options. For example, the pericardium here has two sacs, the fibrous and the visceral. The pleura as well has a parietal and visceral. The visceral is usually, in both cases, attached to the organ itself, and what comes from this area, the pericardium, the visceral in this case, or the visceral pleura in other cases, is similar to the organ itself. The parietal or the fibrous here, which is attached to the parietal pericardium, should be similar to the somatic representation in your body. And the question is, do you know what is the difference between somatic pain and visceral pain? This should be clear. Somatic pain, it is a localized pain that patient comes to you with his finger indicating the source of his pain. Visceral pain, usually it is a vague pain. The patient talks about an area of pain. He will never be able to exactly define this pain. And this very simple definition of the difference of between these two pains is very important for your future ability to evolve the right diagnosis. So let's talk about the pericardium and its nerve supply. The nerve supply of the pericardium is from the phrenic nerve C3, C4, C5, of course. This is cervical plexus, primary source of sensory fibers. Pain, sensation conveyed by these nerves are commonly referred to the skin, C3, C5 dermatomes. It is important to note that the source of somatic sensation, pain, from the parietal pericardium is carried in the phrenic nerve. For this reason, pain related to a pericardial problem may be referred to the supraclavicular region of the shoulder area or the shoulder joint. As I mentioned, the fibrous pericardium is its pain is transmitted, or the sensory inputs transmitted by, of course, the phrenic nerve, which is, by the way, mixed. It has sensory and motor to the diaphragm. Of course, it is phrenic nerve to the diaphragm, and it gets sensory inputs, and this is also of a great clinical value from the peritoneum, from the diaphragm, and from the pericardium. Hang a minute. You did say from the diaphragm. Yes, I did say from the diaphragm. It supplies the diaphragm, especially the central area, by motor, and this area also is supplied by phrenic nerve itself. This area here, where the phrenic nerve supplies the motor, also supplies the sensory. Now, the diaphragm is covered or lined superiorly by the parietal pleura, and inferiorly it is lined by peritoneum, by parietal peritoneum. So above it pleura, below it is the, of course, peritoneum, and in the middle part it is the pericardium. The fibrous is attached to the of course, to the diaphragm. Now, what does this mean? In this area where the phrenic nerve takes the sensory information from the peritoneum that lining the diaphragm, some pain could come from the gallbladder. As you know, the gallbladder is on the right side, and the diaphragm is molded up on the liver itself. What does this mean? Put it in a different way for you. The diaphragm is superior to the liver, posterior to the liver, lateral to the liver, and anterior to the liver. So in one word, I would say it is sheltered in the diaphragm. The shape of the diaphragm is molded and designed to accommodate the liver, if you can put it this way. So the gallbladder, especially the fundus, is touching the diaphragm, especially if there is inflammation. Now, this part of the diaphragm that comes in contact with the gallbladder its sensory is mediated by the phrenic nerve. So the phrenic nerve would take it to C3, C4, C5. Nothing wrong with that. But this is the same root value for this nerve. Supraclavicular nerve. Erb's point at the posterior border of the sternocleidomastoid. These are the sensory branches of the cervical plexus. One of them is this nerve, supraclavicular nerve. It has anterior, middle, posterior. Some people, they just call them different names. It doesn't matter. They supply the shoulder area. They are sensory. Their root value is C3, C4. the same root value for the phrenic nerve. So sometimes, and this is very important for your clinical understanding, it's a very important clinical application. People who have cholecystitis, which is inflammation of the gallbladder, the pain may be perceived by the phrenic nerve, and our brain would think that the pain comes from the shoulder area because they have the same root value, the same nerves. The supraclavicular normally getting the pulses from the shoulder area, the phrenic from the area, the diaphragm, and related to it the gallbladder, as we explained it, and they both ascend up. Now the brain sometimes takes the information from one source and explain it as pain coming from the shoulder, not from the gallbladder. And we call this phenomena referred pain. You need to be understandable that some people they come with signs of pericarditis, but the pain is referred to the shoulder, or people they coming with gallbladder problem and the nerve supply, the inputs are perceived in the shoulder joint. Let me read this to you. The supraclavicular nerve C3, C4, and of course here, which is a branch of the cervical plexus, supplies the skin over the shoulder region. This nerve is important clinically because it shares the same root value with phrenic nerve, and pain may be referred along the supraclavicular nerve from phrenic nerve pericarditis. Okay, so the bottom line is very simple. If a patient comes to you complaining about the shoulder pain, you need to examine the shoulder itself, and if you find the shoulder is fine, think about two conditions: pericarditis, as the phrenic nerve which takes the pain from the pericardium to C3, C4 is has a common station with this nerve, supraclavicular. Also, the phrenic nerve may take information about pain from the gallbladder. So you need to differentiate between a problem in the shoulder, or it is referred from the pericardium and the gallbladder. And to make your life much easier, if you are dealing with the fat female 40, a female whose age is more than 40 or in her 40s, fat and female, those are the risk factors for cholecystitis. Think about cholecystitis. A female comes to you 40 with fat 40 and female, you need to think, and she's complaining about pain in the shoulder joint, around the shoulder area. Please don't you ever dare to forget to check the gallbladder. Of course, here we are talking about pain on the right side. On the left side, you need to consider pericarditis. You need to consider pericarditis. On both sides, you need to consider pericarditis. On the right side, you have to consider also the cholecystitis. Now, pericarditis is the inflammation of pericardium, the fibrous sac surrounding the heart. Symptoms typically include sudden onset of sharp chest pain. The pain may also be felt in the shoulders, neck, or back. This is primary pain. Important pain from the pericardium may be, let me put it this way, it's getting worse by lying back or on the left side and relieved by leaning forward. Of course, we will talk about this in the practical session as we demonstrate and explore the visceral and the parietal pericardium. So what really important about the anatomical features of pericardium, that this sac gives me two sinuses, oblique and transverse sinuses. You need to know the transverse sinus and its application. You need to know the nerve, the blood supply, which is the internal thoracic artery mainly. You need to know the nerve supply to the heart, to the pericardium, which is the phrenic nerve. You need also to ask about the referred pain phenomena. If the patient comes to you with pain radiating on the shoulder, you have to ask about the shoulder itself. Then you have to consider cholecystitis, or you consider pericarditis for your future diagnosis. If you settle down and you think that this is pericarditis, then you should ask the patient to lean backward. If the pain gets worse, this would give you more indication that it is a pericarditis, especially if the patient, when you ask him to lean forward, the pain is getting better, less, I mean. So then you can ask for x-ray, so you can listen to the pericardium. But this is the way we evolve our diagnosis. So from all these slides, I summarized to you what really matter for the exam as well. Now sometimes we do have pericardial effusion. Normally only a tiny amount of fluid is present between the visceral and parietal layers of the pericardium, serous pericardium. In certain situations, this space can be filled with excessive fluid, pericardial effusion. Because the fibrous pericardium is relatively fixed structure that can't expand easily, the fibrous, I mean here, a rapid accumulation of excess fluid within the pericardial sac compresses the heart, causing cardiac tamponade. We said this is a potential space, the pericardial cavity. If for any reason it gets filled, it would be challenged by the outermost layer, which is the fibrous sac, and this is a tough sac, and the fluid won't break it easily, of course, and it would apply pressure backward on the heart itself, causing cardiac tamponade. Removing the fluid with a needle inserted into the pericardial sac can relieve the symptoms, of course. Why the cardiac tamponade is dangerous? The heart is a pump, needs to contract and to relax while it is surrounded by fluid within a very compressed compartment. In this situation, both ventricles won't be able to contract